Okay, so cell wall synthesis inhibition, right? So they're damaging the cell wall in some fashion, or they're preventing the cell wall from being made, right? So when you damage a cell wall, it can stop the production of the bacteria, or it can actually kill the bacteria outright, right? And they thought, oh, it's better, you should kill them all, right? So, but actually they found out there's no difference. As long as you give an antibiotic that's going to either stop it, bacteriostatic, or kill it, bactericidal, that's absolutely fine. There's no difference in the evidence, right? So beta-lactams, those are our workhorses right here. Beta-lactams, again, have all these categories of different varieties of beta-lactams, but we have these are our primary go-to agents that we usually get a patient on, right? We have penicillins up top here, right? So penicillins, and then we have our cephalosporins, and our cephalosporins are split into 4 generations. And then we have our carbapenems. Which ones are the strongest ones? Those are our carbapenems, right? And you can think of medic, right? So MEDIC. So medic is your meropenem. We got ertapenem, doripenem, imipenem, cilastatin. Those are your carbapenems, right? And then your penicillins, they all end in cillin, which is nice, right? So they all have cillin in the name if it's a direct penicillin. And penicillins, they cover gram-positives. That's it, just gram-positives, right? So if they have gram-negatives growing in the cultures, the penicillin is not going to be the best option. It will be the best option if you have a little friend attached along, right? These little beta-lactamase inhibitors. So we know that our beta-lactams, they're going to come on down and they're going to bind to this little peanut butter and jelly protein, right? It's called a PBP protein, right? Or penicillin binding protein. So your penicillins will bind there and they will then stop cell wall production. So what do we do so that happens, but then you know that these drugs are beta-lactams. What does beta-lactam mean? That means it has a little ring in its little organic chemistry, right? And that's important because we have penicillins coming in. And what does the bacteria do? It says, hey, I'm going to kill you, right? I'm a penicillin. I'm going to come in and I'm going to kill you bacteria, right? And the bacteria say, hey, what are you doing? I just hired a hitman. His name is beta-lactamase, right? And beta-lactamase, ACE is an enzyme. It's going to eat apart the beta-lactam rings and inactivate that antibiotics. But then the beta-lactam antibiotic says, you know what? I hired a hitman as well to kill your beta-lactamase, right? So it's a beta-lactamase inhibitor. Right, so these little chemicals are doing, right? It's like playing each other, and ultimately, it actually, yes, it makes it so that it can still kill gram-positives, but actually, they found out that it's going to open up a whole new world, right? A whole new world. It's going to make sure it's going to start breaking down gram-positives and gram-negatives and anaerobes and Pseudomonas, which is great, right? Specifically, Zosin's the one that's our guy that's going to really do all those things, right? The other ones have a little mixed, but they definitely cover gram-positive, gram-negatives. Okay, so our beta-lactamase inhibitors are the ones that are going to really give that antibiotic more virulence, more activity. Okay, and then we have some other drugs in there. We got our vancomycin. We know about vanco. It's nephrotoxic. If you give it too fast, you can start turning red, right? And then vancomycin is a great drug because it covers our MDRO MRSA, right? It also covers C. diff, which is cool. Okay, would you give vancomycin a vancomycin-resistant enterococci? No, that would be a good idea because it's resistant to it, right? So otherwise, it's good for C. diff and it's good for MRSA. And we know people come to the ICU. Do they need MRSA coverage? Yes, because if they're that sick to come to the ICU, and especially if they're hospitalized the last 90 days or so, it's good to give them MRSA because they have MRSA risk factors. What are some other MRSA risk factors besides being hospitalized recently? Close quarters, so homeless or close quarters, immigrant status, where they're coming to it like on a ship or something like that. And then you have a dialysis patients are high risk, right? So you have a dialysis patient who's homeless and was in the hospital last 90 days, definitely needs to have MRSA coverage, right? So vancomycin and usually beta-lactam is usually what patients usually get admitted to the hospital with, especially if they're going to the ICU, all right? And just some of the side effects for our beta-lactams, they all have seizure risk and they all have C. diff risk. So they all can cause C. diff, right? You think, oh, they're getting the vanco, I guess that's going to help. Well, it's only PO vanco that helps, right? Because the PO vanco is like topical vanco for your gut. It's going to go in there, it's going to start coating the C. diff and kill the C. diff. IV vanco is not going to do that. It's not going to make its way into the lumen because it doesn't cover anaerobes. It only covers gram-positives. All right, we have a few other drugs you might see. I just put it here for your information: daptomycin, fosfomycin. Fosfomycin is like our go-to agent for UTIs, like as an outpatient. That's the agent you're going to see most commonly prescribed. Okay, so beta-lactams work where? They work on this thing here, the cell wall, right? So usually, Zosyn is going to be a great one to start with, especially if they're going to ICU, because Zosyn is going to cover gram-positives, gram-negatives, anaerobes, and Pseudomonas, right? Because we know those all can cause virulence, but especially Pseudomonas can cause a lot of problems, right? So that's the idea behind beta-lactams. And then vancomycin is going to also work on the cell wall, but it's going to be working on a different area, a different receptor site, right? So vancomycin and Zosyn is usually a combination you're going to see. All right, so ribosomes. So ribosomes are little proteins inside our bacteria that are spitting out cell wall components and toxins and other things that are going to be causing a lot of problems, right? So we can give antibiotics that are going to stop the ribosomes. They're going to stop the production of further bacteria, right? You need proteins to make more DNA and RNA for replication as well. So we got ACE or macrolides. ACE is the mnemonic, so azithromycin, clarithromycin, and erythromycin. You would think that if it ends in mycin, it must be a certain antibiotic class, but no, they were lazy in naming their medications over the last 75 years. They called every antibiotic mycin after penicillin, like vancomycin. Is that the same thing as azithromycin? No, it's totally different. It doesn't work on the cell wall, it works in the ribosome. It's like you guys could have said, ribomycin or something, I don't know. They could have had another name attached to it. But it's just a way to kind of get oriented to all the mycins, right? Because macrolides are completely different than aminoglycosides, right? So aminoglycosides, almost all of them end in mycin, but they are not the same medication class, right? So the best way to memorize them is just a cute mnemonic, right? So ACE, right? So azithromycin, clarithromycin, and erythromycin. These guys cover atypicals, right? And atypicals grow like in an pneumonia, for instance, right? That's a common place for atypicals to grow. So if someone comes in from the community and they have a pneumonia, we might cover them for, yes, gram-positive, gram-negatives, but also hit them up with an atypical coverage, right? Such as with azithromycin you see commonly, right? COPD patients commonly have a risk for having COPD exacerbation from pneumonias. So usually they want to be on azithromycin, for a year or 6 months or so, or even for life, to make sure that they are not getting a atypical infection just to get them hospitalized, right? What else? So aminoglycosides, these guys are really good for gram-negatives, for Pseudomonas and such. Sometimes they add it on just because if someone's really, really sick, but they've been falling out of favor as far as our go-to agent. Usually they find that just giving coverage for MRSA, coverage for Pseudomonas, cover for gram-positive, gram-negatives, and anaerobes will be just fine, right? And we know that Zosyn Vanco does all those things. Right? But sometimes you'll see someone be on aminoglycoside if they have gram-negative sepsis. How you know that gram-negative sepsis is the blood cultures showed something gram-negative growing, right? And also maybe they were resistant to the first round of antibiotics. Okay, so gram-negative bugs, and Pseudomonas is a gram-negative bug, right? You notice in red here we've been highlighting QTC. So when you have a QTC that's prolonged, that could put you at risk for what? Torsades, right? So that's why when you're on these atypical coverage, that's cool, but you got to look at your QT before you're giving these antibiotics, right? So tetracyclines, tigacycline turns everything orange, but doxycycline is a popular variety that you're going to see. And doxycycline does not prolong the QT. The other ones do, right? The other tetracyclines do. So you'll see someone, they want atypical coverage. It's like, oh shoot, I can't because the QT is prolonged. Well, we have other options, right? We can give them doxycycline. That's usually our go-to agent. And doxy is usually a medication you give for penicillin allergic patients, right? Because it covers gram-positives. Okay. So what else? There's some important ones to point out. Linezolid, you'll see often given. It's like an alternative to Vanco. It's like Vanco's younger brother. But it's not good for pneumonias, but it's good for everything else. Good for skin and soft tissue infections, right? So infections of the skin, linezolid is great. And linezolid, you notice, also covers MRSA. And when I have vancomycin-resistant enterococcus, well, I know that linezolid can work. It's his younger brother, and it's able to do the same things that Vanco does. It's just if they're on as an outpatient, you're going to make sure they're not having any charcuterie boards. Otherwise, you're going to develop a serious MOI-like reaction. Okay? And then clindamycin, that's in the ICU. Rarely you're going to see that. You'll only see that if you have a toxin-producing bug. It's really good at cutting out our gram-positives that cause a toxin to be produced, right? So like necrotizing fasciitis, for instance, produces these little toxins that are spreading and spreading and spreading. They want to cut off with clindamycin, for instance, right? Toxic shock syndrome, which you don't see that commonly, right? Like retained tampons and such, that can cause a toxic shock syndrome. With these toxins being released, that clindamycin can help with, right? So you want to know what drugs prolong QTC. So this mnemonic may help you as well. Like my QTC is fat, my QTC is prolonged. You can think of macrolides, our ACE inhibitors, right? Our ACE inhibitors are azithromycin, clarithromycin, zithromycin. You can think of our fluoroquinolones on the next slide. They prolong the QT. It's another reason why they're not great. And then we got aminoglycosides. That's our PNATs, or P for plasmamycin. Then you got your gent, neomycin, amikacin, tobramycin, and streptomycin. Those are all your aminoglycosides. They all prolong the QT. And then we got our tigacycline, not our tetracyclines, because doxy, right, is not part of that party. It is a tetracycline, but it does not have that effect of prolonging the QT like the other guy in the same class. Okay, and then Bactrim is also a agent that prolongs the QT as well. Okay, so we're talking about the ribosomes that are being inhibited. We already talked about the cell walls being disrupted with our beta-lactams, right? We got our beta-lactams here. We got our cephalosporins, we got our carbapenems, we got our penicillins, right? All those guys can inhibit the cell wall, but sometimes we need some extra support for like atypical coverage. And these guys are going to really work and fix atypicals, because atypicals have a cell wall or don't have a cell wall. Don't have a cell wall. So it makes sense that I need to give an atypical, because it's not going to work on the cell wall. I give vancomycin all day long, but it's not going to work on atypicals, because vancomycin works on the cell wall. Beta-lactams work on the cell wall. Okay, and then DNA, RNA inhibitors, right? So these guys are going to disrupt the DNA function. And you need DNA to procreate, right? So you need to copy your own DNA, and they go through meiosis or mitosis. Which one is it? Mitosis, right? So they separate out and they exponentially divide, right? And if you don't have the DNA to divide into a new cell, you're going to stop that production, right? So DNA inhibitors, right? So fluoroquinolones, they're great. They cause gram-positive, gram-negative, and they have some anaerobic coverage as well, except for one of them. And they also have some atypical coverage. So someone has a hospital-acquired pneumonia, or sorry, community-acquired pneumonia, and then as an outpatient, say, you take some Levaquin, right, levofloxacin, and they're going to be in for 5 days, and they should be all better, right? But it has a lot of bad side effects, including prolonging the QT. It causes really high risk for C. diff infection, right? It can also cause a burn-like reaction, which is this situation here, where we have this Stevens-Johnson syndrome, or toxic epidermal necrolysis. That doesn't sound good at all. Necrolysis means it's eating through your tissue, causing it to become necrotic, and it's toxic, and it's your skin, right? Epidermal. So that can happen with fluoroquinolones. That can also happen with Bactrim, right? Bactrim is great, but it can also have that side effect of burning your skin off, right? There are other drugs out there, but these are the two drugs that are very common at causing this reaction. And it's usually if they have a sulfa allergy, especially with Bactrim, which is what? Trimethoprim sulfamethoxazole, right? So that's where you would really ask, do you have a sulfa allergy, right? Usually why a patient would say they have a sulfa allergy is because they probably had Bactrim in the past, and they developed a rash, or that rash can then develop into a burn-like situation. Okay, so fluoroquinolones are an option to disrupt DNA synthesis, but they have all these bad side effects, including C. diff. And then we have our Flagyl, right? Flagyl is not a fluoroquinolone, but Flagyl is like a Trojan horse, right? It just gets in there, it goes right through the cell wall. Actually doesn't get slip on through like levofloxacin does. It actually is going to be knocked at the door, and they're going to let it in because it resembles one of their own proteins. And it gets in there, and it then gets loose, and it starts disrupting the DNA, RNA. Okay, and it's great for anaerobes, right? So you're going to see everybody that has a GI sepsis or GI infection are always on Flagyl, right? So, and ironically, it also is going to destroy all the bacteria and let C. diff proliferate, right? So one of our side effects for Flagyl is C. diff. And ironically, one of the treatments for C. diff is Flagyl. So it's like, hey, we give you Flagyl to cause C. diff. I don't want that. No, but it's going to treat your C. diff. So that's a hard sell. Okay, you usually do a course of Vanco first, then you do Flagyl afterwards. And then we have something like fancy, like fidaxomicin, which is pretty pricey as well for C. diff. All right, what else? So we have our Bactrim, we got our fluoroquinolones, all right? Do we use fluoroquinolones in the ICU or in the hospital at all? It's very, very rare that you would be using these guys, right? They'd have to have a really, really bad bug to be using this, right? As far as our usual gambit of medications, it's not going to be fluoroquinolones for sure, right? You're going to make a pharmacist, call you immediately if someone orders fluoroquinolones, right? And we have a few other drugs on there, just your TB drugs also work in the on the DNA and RNA specifically. All right, these are treated like a burn victim when you get this toxic reaction. And besides that happening, your fluoroquinolones can also cause your tendon to rupture right there. You see that tendon rupture, and that's not a pleasant sensation. So it sounds like you are getting shot. All right. All right, so our final slide, antibiotics. Again, this is summarizing everything we've been talking about so far. All right, so in the corner here, we have all of our different sources of infection that a hospitalized patient comes in with, right? They might have a skin and soft tissue infection, or SSTI, right? So skin and soft tissue infection it's caused by a bug that's probably on the skin. So it's probably a staph or a strep, and it could be resistant staph. If you have a patient that was in a dialysis center or homeless or in the hospital recently, they could have MRSA. So we might have to cover MRSA with our go-to friend, vancomycin. That's usually our go-to agent. Would linezolid work? Yes, that works as well, right? Why would they choose linezolid over vancomycin from the beginning? It's like in our last hospital stay, they were on vancomycin. That didn't work. So this hospital stay, we're going to try something different. Usually you don't use the same antibiotic they had before. They probably will develop resistance, especially if it's causing the same infection again, right? So they had like a MRSA pneumonia originally. Well, that's a bad example because linezolid doesn't work with pneumonias. But if they had let's say a UTI, for instance, right? So with MRSA, you wouldn't give the same bug or same antibiotic for that bug because that's probably what's causing it this time as well if they're coming back to the hospital. Okay, but if they have a skin infection, we're going to cover for MRSA for sure, and we're going to cover for something gram-positive, gram-negative, right? It's broad spectrum. So what covers broad spectrum stuff? Does just straight up penicillin do it? No, that's weak. That only covers gram-positives. So we got to give something that's going to be more broad spectrum. And if they're coming to ICU, we're going to definitely hit them up with something stronger, like a tank, like a medic, right? You're going to use a meropenem or ertapenem variety, right? Otherwise, if they're just going to the floor, then something like ceftriaxone, which is one of our cephalosporins. And cephalosporins are under what class? Cephalosporin, you got first generation, second generation, third generation, fourth generation, right? And it's also kind of penicillins are its brothers, right? And our carbapenems are its brothers as well, because these are all beta-lactams, right? So beta-lactams can cause can inhibit cell walls, and there's certain beta-lactams that have gram-positive and gram-negative coverage, right? And ceftriaxone is usually the one you always cef-try on everybody, right? It's always, so everybody on ceftriaxone, right? So ceftriaxone and Vanco for someone that's pretty sick or has risk factors for MRSA, right? So MRSA risk factors, again, they got skin and soft tissue infections. They have known colonization history of MRSA, right? They have, and how do you know someone has MRSA in the hospital? You swab them, right? Everyone comes to the ICU. The standard is that everybody gets swabbed for MRSA because worst case scenario, they could have MRSA, right? They have a MRSA pneumonia as well. All right, so those are skin and soft tissue infections, right? And again, going back to SSTIs, you could be something gram-positive growing, it could be gram-negative growing, or some anaerobes growing, especially if it's an abscess, right? People get abscesses in their skin, right? We got to give something that's going to cover abscesses, right? So that's some of the antibiotic choices that we would be thinking about. And then pneumonias. So pneumonias have two types. You've got community-acquired and hospital-acquired. The reason why it's hospital-acquired is you were in the hospital recently. How recent? 90 days. So you're in the hospital last 90 days, and now you're back with pneumonia. Or you didn't have pneumonia before, but you have pneumonia now. All right, in the last 90 days, that's considered a hospital-acquired pneumonia. Okay, and if it wasn't that, it was beyond 90 days, then it's community-acquired, right? Certain patient populations are more at risk for community-acquired, like patients that are immunocompromised, patients that are COPD, for instance, are high risk for community-acquired pneumonias. And in community-acquired pneumonias is where you develop atypical infections, right? Atypicals such as mycoplasma pneumonia that don't have a cell wall can cause a pneumonia to happen. What's the most common pneumonia though? Is strep pneumonia, Haemophilus influenza pneumonia. Those are gram-positive, gram-negative bugs, right? So so someone comes in, even though like 10-20% of the time it's atypicals, the other 80-70% of the time it's the other guys, we're going to still cover for all the things, right? So we're going to cover things for atypical coverage, right? And we're going to cover for gram-positive, gram-negatives, right? We could just be done with fluoroquinolones, but if they're getting hospitalized, we're not going to be giving fluoroquinolones because they have all kinds of bad side effects. On the outpatient side, though, we can give fluoroquinolones. They are okay, right? We just got to make sure they know what side effects to expect. All right, so fluoroquinolones, or we're going to do beta-lactams, right? And beta-lactams, do any beta-lactams cover atypicals? If you look back, I didn't put any kind of rainbow colors on your beta-lactam chart, right? So no beta-lactam covers atypicals. So we got to go to the second page to look at things that disrupt DNA, RNA, or disrupt ribosomes. So because atypicals, do they have a cell wall? No. So that's why beta-lactams don't work on them, because beta-lactams work on the cell wall. But we need to find something atypical. What covers atypicals? A macrolide. What's macrolide? They all end in mycin. You're not going to be wrong to say, oh, this one that ends in mycin, right? You're not going to be wrong, but it is the ones that are ACE, right? So ACE, you got azithromycin, clarithromycin, and erythromycin, right? Those are your 3 medications that cover atypicals, right? You see someone on gram-positive, gram-negative coverage, so they're going to be on not just a penicillin, but maybe a cephalosporin. Not a first generation, because first generations only cover gram-positives. Maybe like a second generation one we want to try, like ceftriaxone, right? So we're going to do ceftriaxone and azithromycin, for instance. It's like, oh, shoot, QT is 0.56, right? So you're going to, okay, we're going to switch it from azithromycin to doxycycline, for instance, because doxy also covers atypicals. If you have a choice between the two, well, yes, you could choose levofloxacin, but then you're going to call the pharmacy right away, right? It's like, what are you doing? Why are you doing levofloxacin, right? So yeah, that's why usually doxycycline is the one we kind of settle on. Okay, it's not as strong though. Azithromycin is much, much stronger than doxycycline. Okay, and then switching gears to hospital-acquired pneumonia. Obviously, they are sicker, right? And they had a risk for hospital exposure, and they're now a risk for exposure to hospital bugs, such as MRSA, right? But also things such as Pseudomonas, right? Pseudomonas is green, and Pseudomonas forms green sputum, but also it's going to be very, very virulent. It's going to cause a lot of disease and sepsis and septic shock. So giving a coverage for Pseudomonas is probably a good idea, right? And a Pseudomonas anaerobe, no, but we would definitely want something that can cover gram-positive, gram-negatives, because it might not be Pseudomonas. It might just be a regular strep pneumoniae, right? But it could be Pseudomonas pneumonia. So we're going to give beta-lactam that covers Pseudomonas. Which one does? Not Vanco. Vanco is for MRSA. So we're definitely going to give MRSA coverage, right? For sure, right? And what do you say? There are other antibiotics besides vancomycin, right? Because Zosyn is going to cover all those options, right? It's going to cover gram-positive, gram-negatives, anaerobes, and Pseudomonas, right? And yes, Pseudomonas is a gram-negative, but we want to make sure we have some Pseudomonas coverage, such as Zosyn, right? And then we have like cefepime covers Pseudomonas. It doesn't have anaerobe coverage, but it does have some Pseudomonas coverage. You're going to see a lot of people on cefepime when they come in pneumonia. Cefepime and Vanco, right? And sometimes they'll also be on atypical coverage as well, right? And what's atypical? That's your macrolide down here, and that, or it's going to be your doxycycline, or Levaquin if pharmacy left for the day, right? So those are your options for atypical coverage. And then gram-positive, gram-negative, that's our Zosyn or our cefepime, right? And meropenem, oh yeah, that's going to cover all the things, right? Meropenem is going to cover your gram-positive, gram-negative, anaerobes, and your Pseudomonas. So why don't I just put everyone on meropenem? And why is everybody on Zosyn? Because Zosyn is like a bazooka, right? If you think of like the artillery-wise, and meropenem is our tank, right? So if you start someone on Zosyn, right, or cefepime, and then they're getting sicker, your pressure requirements are going up and going up, you should be making a phone call and say, hey, we should be maybe escalating antibiotics, right? Because this bazooka is not doing the job for this invading zombie apocalypse of bacteria that are proliferating and proliferating, right? So they can then reevaluate and say, oh yeah, let's go ahead and do meropenem. If you come in, you get a report, you're on meropenem, you know you're on the strongest stuff. Should you be on the strongest stuff? I don't know. But usually you're on meropenem, they're on a couple pressors, they're really sick, the oxygen requirements are really high if they have a pneumonia brewing, right? So that's how you know the difference and why they would choose one over the other, because they both cover the same stuff, but one is stronger than the other one. Okay, and then next we have UTIs, right? So UTIs, they have their classic clinical presentation of like fever, flank pain, etc. But how do you know if it's community-acquired UTI or a hospital-acquired UTI? Same thing. Were you in the hospital last 90 days, or did you develop a UTI in the hospital stay right now, right? You've been in the hospital for 10 days, you had a Foley for 10 days, or you came in with a Foley and no one changed it, and now you have this UTI that's developing in the hospital setting, right? That's how you know it's a hospital-acquired infection. Which one's worse? Probably the one that's hospital acquired, because there's a lot of bad bugs that are in the hospital, right? You have patients that actually sign waivers and say, I want to be in the hospital one more night. Are you sure? Do you know what grows here, right? There's a lot of bad stuff. So, it's not good to be in the ICU longer than you have to. It's not good to be in the hospital longer than you have to, right? So community-acquired UTIs, such as they come in with a UTI from the field, or from the community, and they don't have risk factors. For MRSA, that means they're not dialysis. Dialysis is probably not peeing much, right? But you're not immunocompromised. You're not homeless. All these things put you at risk factors for MRSA, right? So it's usually gram-negative bugs, because that's where they've come from the gut, right? Through the anus, and have made their way up into the urinary tract. And that space is the space between is about 1 to 2 centimeters, or 2 to 3 centimeters, and especially in women compared to men, right? Men have more than 2 centimeters to work with. So it's very, very uncommon for a guy to have a UTI, right? Unless they've, of course, have sexual interactions, but it's very uncommon for them compared to women, right? So for a guy to get a UTI to come to the hospital, you could look at sexual history, but also you could look to see, do they have a Foley catheter use recently? Do they have a risk of instrumentation recently, like a prostate surgery or something to that effect, right? So community-acquired UTIs, or fosfamycin, like we mentioned, is usually our go-to agent, but we can give other stuff that would cover gram-negatives. Right? That's usually what we're going to be given for these guys. But a hospital-acquired UTI, that's your sicker patient because of a UTI. And we're going to be definitely covering gram-positives, gram-negatives. Right? Atypicals? No, because atypicals don't grow in the urine, right? They usually are going to be growing in the lungs. So we're definitely giving beta-lactams, right? Some pretty strong, because if they were in the hospital recently, they could have picked up Pseudomonas, or they could have picked up MRSA. Both of these cause pneumonias, and both of these cause UTIs, right? So we definitely want to get some Pseudomonas coverage. So we need to be on this list. Maybe have some Pseudomonas coverage. Right? If your patient's getting sicker and sicker and sicker, might be because they don't have Pseudomonas coverage. They were on ceftriaxone, which you try on everybody, but that doesn't have Pseudomonas coverage, and that doesn't have anaerobe coverage either, right? And anaerobes, we know, can grow in the bladder. Okay, so that's the idea. And then why is vancomycin there? Well, it's because you can also get MRSA in the bladder, right? You can also get a UTI from MRSA. All right, switching gears to abdominal infections, right? So abdominal infections, use your gram-negative bugs, but there are some gram-positives in there as well. So what are we going to cover for? Gram-positive, gram-negatives, that makes sense. And also it's the space between as well is going to be the lumen inside. Also can be a space where you can grow extra bacteria, right? Or I should say anaerobes that don't require oxygen. They just live inside that lumen. So we want to make sure we are on something that covers anaerobes, and that's where we bring in our friend Flagyl or metronidazole, right? That guy's definitely going to cover it, right? Do you need double anaerobe coverage? Do you need to be on Zosyn, which covers anaerobes and Flagyl? You're going to see it, but the evidence says you don't need to be on both. As long as you're covering gram-positive, gram-negatives, and you're covering some anaerobes, that's fine, right? And then Vanco, just there for good measure. Okay, the most common bugs can be everything. It can even be fungus, right, or fungi. So you can even cover for you might see a patient like fluconazole, for instance, antifungal. So why that antifungal? So it's because they have an abdominal process. That's what's going on, especially if your patient's immunocompromised. All right, our last piece is our patient that is unknown. They don't have a clear skin and soft tissue infection. You looked them over, you didn't see any kind of abscesses, any kind of osteomyelitis, no decubiti, and you looked at their lungs, and lungs were clear, X-ray looked beautiful, all right? They're on 35% on the ventilator, and you look at the belly, the CT scan of the belly, belly's intact, there's no colitis, there's no diverticulitis, appendicitis, gallbladder issues, T-Billy's negative, you know, B and creatinine, yeah, might be elevated, but there's no UTI as well. The leukoesterase and nitrites were negative. Everything's negative. What the heck's going on? But right in front of you, they are super sick, right? They're on 2 pressors, and they are not waking up at all. So that's when we go to unknown source. Don't know what it is. It's not pneumonia. It's not UTI. It's not a skin infection. Therefore, we're going to hit them with the strongest stuff, right? We're going to cover all. If they're in ICU, we're covered with this. We can hit them with a tank, right? We hit them up with a carbapenem, or you could do like cefepime or Zosyn, but you got to make sure you're covering all the things: gram-positive, gram-negatives, anaerobes, and Pseudomonas, as well as MRSA. That's why vancomycin is usually always part of the plate in the first 24 hours, or it's probably usually always one of your go-to antibiotics. Unless you know they have a history of this, then you can maybe switch it up to something else, right? So we have options that are, just chunky mild, right? It's my username. And then we also have things that are, super extra spicy, right? These are spicier diseases, and also they might require spicier antibiotics. All right, so that's antibiotics in a nutshell. So it's, yes, it's complicated, but the idea is to make sure you're covering for the sickest of sick patients, right? Make sure you're covering for MRSA, make sure you're covering for Pseudomonas, and there could be anaerobes in there as well. So you got to figure out what anaerobes antibiotics are they on? Are they checking all the boxes? Like Zosyn checks all the boxes except for MRSA. So I need to be on something that checks all the boxes plus vancomycin. Now I'm covered, right? And then like atypicals. Zosyn doesn't have atypicals. Vanco doesn't have atypicals. So you might be on something that covers atypicals. What are atypicals, right? Fluoroquinolones, please don't use those, right? And you want to make sure, and then we got, doxycycline, or we have our ACE inhibitors. Our ACE inhibitors are ACE drugs, our macrolides. All right, so that's all about antibiotics.